beta 1 and beta 2 receptors. And these are the drugs which are agonists on these receptors. Okay? They are the agonists on the receptors. Okay, epinephrine, this is the primary hormone secreted by the adrenal medulla in mammals, about 80 to 90%. Okay? This norepinephrine is the major neurotransmitter in the peripheral sympathetic nervous system and in the post-ganglionic adrenergic nerve. What is the neurotransmitter in the pre-ganglionic adrenergic nerve? Your? Again? Louder. Acetylcholine. Okay? The neurotransmitter for all preganglionic nerve fibers, whether it is adrenergic or cholinergic, is acetylcholine. Okay? But for the post-ganglionic adrenergic nerves, it is norepinephrine. For the cholinergic, it is both acetylcholine. Okay? So your dopamine is found predominantly in the basal ganglia of the CNS. Okay? So what will be the effect of your epinephrine? Okay? Epinephrine is a potent stimulant both for the alpha and the beta receptors. So the effects will depend on the target organ complex, on the effector tissue. Okay? It is a powerful cardiac stimulant. Okay? Predominantly, it acts on the beta 1 receptors of the myocardium and the cells of the pacemaker. And then it also affects respiration by the relaxation of the bronchial smooth muscles. Remember, this was the drug of choice for anaphylaxis. It can relax the bronchial muscle, so it can reverse the bronchoconstriction caused by anaphylaxis. Okay. What are the direct responses when they act on the receptors? So, by acting on the beta 1 receptors, there will be increase in the blood pressure due to the positive inotropic and chronotropic activity. Okay? If they act on the alpha receptors, there will be vasoconstriction. And then if they act on the beta 2 receptors, which are found in the skeletal muscles, then there will be increased blood flow to the muscles during exercise. Okay, on the GI tract, okay, there is relaxation of the smooth muscles of the GI tract because of the activation of both your alpha and beta adrenergic receptors. Okay? So the intestinal tone and the frequency and amplitude of spontaneous contractions of the GI tract are reduced. Okay? Remember the relaxation of the smooth muscles. Stomach is also relaxed. Okay? But the sphincters are contracted. Okay? Pyloric and ileocecal sphincters are contracted. On the uterus, okay? The spans of the uterine muscles will vary depending upon the species, age of sexual cycle, age of gestation, and the age. Okay, so mainly the effect on the human uterus is inhibition of uterine tone and contractions during the last trimester. Okay? Inhibition of uterine tone and contractions during the last trimester. Okay, on the urinary bladder, Okay, practically your ANS will affect the whole body from head to toe. Okay? On the urinary bladder, okay, there will be relaxation of the detrusor muscle, and this is due to activation of the beta receptors. Okay? Beta receptors, detrusor muscle of the bladder. And then there will be contraction of the trigo and the sphincter muscles due to the action on alpha receptors. And then there is what? Smooth muscle contraction in the prostate. So these are the different effects of your adrenergic stimulation. Metabolic effects, okay, on insulin secretion. Okay, if the alpha-2 receptors are activated, there is inhibition of insulin secretion. So what will happen if there is no insulin? Hyperglycemia. And then beta-2 receptors activation will lead to enhancement of insulin secretion. So what will happen? Hyperglycemia. Okay. Glucagon secretion is also enhanced by the action on the beta receptors. Okay? The beta receptors which are located at the alpha cells of the pancreatic islets. And then there is a decrease in the uptake of glucose by peripheral tissues. So the glucose will stay where? In the blood. And untoward effects, restlessness, apprehension, headache, and tremors, which may be secondary to the effects on the cardiovascular system, the skeletal muscles, and your intermediary metabolism. Okay, so your epinephrine is available in these preparations. Okay, 1 is to 1,000, 1 is to 10,000, and 1 is to 100,000. Okay. What is the unit of 1? The unit of 1 here is 1 gram. 1,000 is ml, milliliter. Okay? 1 gram in 1,000 milliliters, 1 gram in 10,000 milliliters, and 1 gram in 100,000 milliliters. Okay, those are the usual. Now, the usual dose of your epinephrine for our anaphylaxis is your 0.3 to 0.5 milligrams, okay, given subcutaneously. But for cardiac arrest, you give it intravenously at a dose of 1 milligram. Okay? Can also be given through inhalation. Okay? And the dilution for inhalation is 1 is to 100. And this is the 1% population. So what do you mean by percent? Percent means grams per 100 ml. Remember, this is gram, this is 100 ml. So that is 1%. So 1 gram in 100 ml is 1%. Okay? So that is how you compute for your percentage concentration. Okay, for norepinephrine. Okay? Your norepinephrine lacks the methyl substitution in the amino group. Okay? And it is about 10 to 20% of the catecholamine content of the human adrenal gland. Epinephrine is 80 to 90. Okay? It is a potent agonist at the alpha receptors. Okay, but it is less potent than your epinephrine on the alpha receptors of most organs. But when it comes to blood vessels, okay, alpha receptors, it is your norepinephrine. That's why it is the one being used for the treatment of shock. Okay? So your norepinephrine will also increase coronary blood flow. Okay? Indirectly. And directly induce coronary dilatation and this cause of elevated blood pressure. So there will be increase in coronary blood flow. And for your dopamine, dopamine is a central neurotransmitter. Okay? So it works in the CNS. Okay? Dopamine 1 receptors located in the vascular beds lead to vasodilation. Okay? So dopamine will also activate the beta 1 receptors in the heart. Okay? That's why it can also what? Stimulate the heart contraction. Okay, your dopamine at low doses, okay, when given at low doses, it can decrease peripheral resistance, leading to vasodilation. So if you hear this in the hospital, give a renal dose of dopamine, it means that dopamine will be given at low doses, and the purpose is for them to dilate the renal blood vessels so as not to injure the kidney, to prevent kidney injury. Okay? And then at higher doses, your dopamine will now activate the alpha receptors, so there will be vasoconstriction, even in the renal vascular system. Okay? And when it is given at high rates of infusion, then your dopamine now will mimic the action of epinephrine. Okay? High doses. Okay, so these are the different clinical uses. Epinephrine for bronchospasm, hypersensitivity reactions, cardiac arrest, okay? Post-intubation respiratory problems, and for your infectious disease. Okay? Norepinephrine for shock and hypotension, and your dopamine for congestive heart failure with oliguria and low or normal peripheral resistance, as well as for cardiogenic and septic shock. Okay. Dopamine-related drugs, these are your phenoldiazepam and your dupexamine. Okay? The phenoldiazepam is a dopamine 1 receptor selective agonist, and it lowers blood pressure in severe hypertension. Okay? So whether dupexamine, this is a synthetic. Okay? Synthetic analog related to your dopamine with intrinsic activity at your dopamine receptors, as well as at the beta-2 adrenergic receptors. So they are used in patients with severe congestive heart failure, sepsis, and shock. Okay, so this is just the list of the alpha-2 selective agonists, selected for the alpha-2 receptors. The clinically important drugs here, okay, that are being used nowadays is your clonidine and your methyldopa, as well as your dexmedetomidine. Okay? These clonidine and methyldopa are being used as anti-hypertensives. Clonidine and your methyldopa. Okay? While your dexmedetomidine, this is being used for sedation of your intubated patients and those who are under ventilatory support in the ICU. Okay, this one, this silomethazoline and oxymethazoline, they are commonly used as topical decongestants, okay? Because they can constrict nasal mucosa, the nasal blood vessels in the nasal mucosa. Okay, beta agonist. Okay? Beta adrenergic agonist. Okay, so you have beta 1 selective and beta 2 selective. So these are the beta 1 selective, And these are the beta-2 selective. Most of these drugs, you know, they are being used in maybe some body can using this, or some of you, asthma, right? So these are for your beta-2 selective agonist for asthma and for what? For your preterm labor. Okay? So the mixed acting, you have your ephedrine, pseudoephedrine, and phenylpropanol. Okay? So this pseudoephedrine, okay, it is also available for found in your OTC drugs like your decongestants. Okay? Again, I inserted this to remind you that you have to memorize this. Okay, and this is the flower from which ephedrine was derived. Okay? Nice flowers, no? Looks like fruits. Okay, indirect acting adrenergic agonist. Remember, you have three: the releasing agents, the uptake inhibitors, and the enzyme inhibitors. Okay. So under releasing agents, you have your amphetamine and tyramine. Uptake inhibitors, your cocaine and your TCAs. Okay. On the MAO inhibitors and the COMT inhibitors, your bargibine and tacopol. Okay. Amphetamine, this is a CNS stimulant. Okay. And this readily enters the CNS. Okay. The peripheral action of your amphetamine is mediated through catecholamine release. Okay. At moderate doses, your amphetamine can produce restlessness, insomnia, and anxiety. And at high doses, you can have paranoia. Okay. What are the actions of your amphetamine? It is an alerting drug. Okay? Sleep deterring activity, and it can improve attention. Okay? Loss of appetite, okay? So leading to weight loss. But long-term exposure to your amphetamine, you can no longer achieve this objective or goal. Okay? And this is being used therapeutically for narcolepsy. Then modafinil, this is an amphetamine substitute for narcolepsy. Okay. Family still of the amphetamine. In methamphetamine, it has a higher ratio of CNS to peripheral actions compared to your amphetamine. Amphetamine is what? This is your okay? Phenylprazine is an amphetamine-like effect being used as anorexia to decrease appetite for those who are trying to lose weight. And then methylphenidate or Ritalin, this is being used in children with ADHD. Okay, the uptake inhibitors, one is cocaine. And cocaine is actually a local anesthetic that inhibits norepinephrine reuptake. Okay, so it produces an amphetamine-like effect, but shorter lasting and more intense than the effect of amphetamine. A major action of cocaine in the CNS is peripherally, this is the action, inhibition of norepinephrine uptake. Okay? Centrally in the brain, okay, in the CNS, the action is to inhibit dopamine reuptake into the neurons in the pleasure centers of the brain. Remember, dopamine is the neurotransmitter associated with pleasure and addiction. Okay? That's why your cocaine is addictive. Cocaine may precipitate convulsions, cerebral hemorrhage, arrhythmias, or myocardial infarctus. And these are the usual causes of death for cocaine overdose. Okay, another is tyramine. Okay? Tyramine is a byproduct in the body after metabolism by the enzyme monoamine oxidase. Okay? It is found in high concentrations in fermented foods such as what we love, cheese. Okay? So it releases the stored catecholamines and has a noradrenaline or noradrenergic like effect. Okay? So those patients who are receiving or taking MAO inhibitors, the effect of tyramine may be greatly intensified. Okay? Remember, tyramine is a byproduct of metabolism by monoamine oxidase. Okay? So, in a patient taking anti-reversible MAO inhibitor drug, 20 to 50 milligrams of tyramine increases the blood pressure significantly. Okay? So, tyramine-rich foods, ito. Okay? This looks like pizza, right? Cheese, sausage, pickled fish, and yeast supplements, they contain sufficient amount of tyramine to be used. The organ system effects. Okay, so remember you have to know the receptors, where they are located, and then you will know what will be the effect. Okay? So for the alpha 1, they are located in the most posterior smooth muscles. Okay? So there will be contraction of most blood vessels or vasoconstriction. They are found in the pupillary dilator muscles. So there will be pupillary dilatation. Okay? And then they are also found in the pilomotor smooth muscle. So there will be piloerection. Okay? They are also found in the prostate, so there is contraction of the muscles of the prostate. And they are found in the heart, so there is increased force of contraction. Okay? Or inotropic effect. Okay, alpha 2. Alpha 2 receptors, they are found in the postsynaptic CNS adrenal sector. Again? For the heart?
Beta 1 is the receptor.
Beta 1, yeah. But we haven't discussed it yet. We are still in alpha 1, alpha 2. Which one?
In alpha 1 we have mentioned already.
Huh?
In alpha 1 we have mentioned already. Contraction, the increased force of contraction. Heart.
Yeah.
Yeah.
Alpha 1 is for inotropic. Inotropic. Okay? Your beta 1 is both inotropic and chronotropic. But both of them will increase the contractility of the heart. Okay, so your alpha 2, okay, you will have multiple actions because of this action, because they are located in the postsynaptic CNS adrenal receptors. Alpha 2 receptors located in the platelets, when activated, there will be platelet aggregation. Okay. The adrenergic and cholinergic nerve terminals, okay, can either lead the inhibition and release of your neurotransmitters. Okay, vascular muscles, they will also contract. Some vascular muscles. Fat cells, inhibition of lipolysis. The alpha-2 receptors in fat cells, inhibition of lipolysis, because there is another receptor located in the fat cells. Okay? Now, this is your beta 1. This is what you were asking. Okay? On the heart, it is both force and rate. Okay? Both inotropy and chronotropy. Okay? For alpha, it is
I know trophy.
inotropy. Okay, so your beta 1 receptors are also located in the juxta glomerular cells. So there will be okay, so there will be an increase in your renin release. Activation of your trans. Okay? Beta 2 receptors are found in the smooth muscles. Wala. Okay, so they are found in the smooth muscles of the respiratory tract, okay, smooth muscles of the uterus, and the smooth muscles of the blood vessels. So there will be relaxation of these smooth muscles. That's why beta 2 agonists are being used for what disease? Because you need relaxation of the respiratory muscles, your asthma.
Asthma.
Relaxation of uterine muscles, so they are being used for
Pregnant.
preterm
Labor.
Kausuhan lang, bumili kami gusto. Sa hiyakit kami. Nahiya kami sa iyo. Okay, so for the beta 2 receptors, they're also located in the skeletal muscles. And when these are activated, there will be potassium uptake. So potassium will be uptaken into the muscles. So what will happen to the level of serum potassium?
Increase.
Okay.
Potassium.
So the beta 2 receptors in the human liver, the action is glycogenolysis, okay? Breakdown of glycogen. Okay, beta 3 located in fat cells. If these are activated, my fats will go away. Okay, glycolysis. Okay, dopamine 1 receptor found in the smooth muscles. Okay, that is renal vasodilatation. And then the dopamine 2 receptors, which are located in the nerve endings, when they are activated, there will be modulation of transmitter release. And so in summary, the effect of your adrenergic agonist on the cardiovascular system by acting on the alpha receptors, you have increased arterial resistance, increased blood pressure. Okay? Alpha-2 agonist will decrease blood pressure by actions in the CNS through the direct effect on a blood pressure. Okay? It may be constriction. That's why the alpha-2 agonists that we saw earlier, your methyl, dopa, and your clonidine are being used for hypertension. Okay, your beta receptors, your beta 1, direct. Beta 1 has direct effect on the heart more than the beta 2 receptors. Okay, beta 1 selective agonists do not induce vasodilatation, so they increase cardiac output with less reflex tachycardia. Okay? And the beta-2 receptors will decrease arterial resistance. Okay? Because of vasodilatation. Okay? After agonists, we come to your adrenergic blockers. Okay? So they are classified according to their selective affinity. Either selective alpha 1 or selective alpha 2. Okay. Based on reversibility, some will be irreversible, some will be reversible. Okay? So the clue here is which one is the longer word? Irreversible or reversible? So it is long acting. Okay? Irreversible, long acting. Okay. So, example of an irreversible, long-acting alpha blocker would be your phenoxybenzamine. And the reversible, short-acting is your phentolamine. Again, which one is short or longer? Phenoxybenzamine or phentolamine? Phenoxybenzamine, that's why it is irreversible and it is long-acting. So you should not forget that. Okay? And then the other short-acting ones are your prazosin and your tolazepam. Okay? Okay, alpha-1 blockers. Okay, prototype is your prazosin. Okay? So these are your osin. And the alpha-2 blockers, your lomendin and your wolfsin. This tamsulosin is being used in the field of urology. Okay? So you use alpha-1 blockers. Okay, what would be the effects of alpha blockers? Siyempre, it's the opposite of the alpha agonist. Okay, remember? They will block the receptor. So the function of the receptors or action will not happen. Okay. So lowering of peripheral vascular resistance, decrease in blood pressure, orthostatic hypotension, reflex tachycardia, and there could be exaggerated tachycardia with the use of phenoxybenzamine, phentolamine, and tolazepam. Okay? So that's why these drugs are dangerous in the hands of non-experts. You don't see general practitioners using these drugs. Okay, other effects of your alpha blockers. Remember, alpha agonists will produce mydriasis. So alpha blockers, you have your meiosis. Okay? Nasal stuffiness, and decrease resistance to urinary blood. That's why your tamsulosin is being used in urology, okay, for urinary retention, because it can decrease resistance to urinary blood. Okay, clinical uses of the non-selective alpha blockers. You are phenoxybenzamine. Okay. This is being used during the preparation of patients for surgery because of pheochromocytoma. Okay? And then for carcinoid tumors and mastocytosis. While the phentolamine are being used at times during surgery when there is increase in the blood pressure during surgery. For Raynaud's phenomenon, erectile dysfunction, and accidental local infiltration of alpha agonist. Okay, so adverse effect, orthostatic hypotension, reflex tachycardia, first dose hypotension. That's why if you're going to give alpha blockers for hypertension, the first dose should be witnessed Okay, there should be a doctor or at least a nurse because of this first dose hypotension. Then nausea, vomiting, and angina in patients with coronary artery disease. Okay, so this is just a summary of everything that we have discussed. Okay, the agonist potency order. Okay, so the most potent is A is adrenaline. Okay, and A is noradrenaline. Adrenaline is the same as epinephrine. Noradrenaline is the same as norepinephrine. And this is isotopic. We have discussed it. So this is just a table giving you the summary of what that is. Now we go to your beta blockers. Okay, beta blockers are all competitive antagonists. Okay, and the prototype is short propranolol. Okay, so the classification is based on their beta subtype selectivity, okay, whether they are selective for beta 1 or for the beta 2. Okay, partial agonist activity, lipid solubility, and local anesthetic action. Okay? So beta 1 selectives, these are just examples of your beta 1 selectives and your beta 2 selective. Although these beta 2 selective blockers have no clinical use, they are usually used in researches. Okay. Non-selective beta blockers, short propranolol. Okay, that's why for patients with asthma, okay, if you give your propranolol, patient will be 6 feet below the ground. Okay, remember that. You don't give your non-selective beta blocker for your patients with respiratory problems, asthma and COPD. Okay? There are some beta 1 selective which we can use, okay, but not all. So as general practitioner, do not attempt to do that. And then those who have selectivity for both the beta and alpha receptor, that is your labetalol. So your labetalol can block both the beta receptor and the alpha receptor. Okay. Those who have partial agonist activity, this is because they have intrinsic sympathomimetic activity. Okay? These are the examples, your pindolol, acetylolol, and labetalol. They may be useful in patients with asthma. Okay? Now those with local anesthetic activity. All beta blockers have local anesthetic activity except for timolol. Okay, so the main disadvantage when these beta blockers, okay, are being used on the eye topically, they might injure their eyes without knowing it because of this local anesthetic activity. Okay? Lipid solubility, so this is the characteristic of beta blockers which is responsible for the CNS adverse effects of your beta blockers because they can traverse the blood-brain barrier. Okay. So the drugs which have moderate lipid solubility are your carvedilol, metoprolol, and pindolol. Okay? And then those which are highly lipid soluble are your carglucolol and your propranolol. Okay, this is just a rapid illustration of the potential risks and dangers when you are using beta blockers. Bradycardia, okay, heart block, congestive heart failure, blood sugar will increase, diabetes, and then since they can traverse the blood-brain barrier, there could be CNS effects like sedation, fatigue, and sleep alteration. Okay? So again, summary of the different alpha receptor antagonists, their classification and the members. The beta receptor antagonists, you have your first generation, second, third generation. Your non-selective, the third generation are both non-selective and beta-selective. Okay? While you're here, the first generation are all non-selective. So they discovered the beta-2 selective. So this is the second generation. And then again, they discovered the third generation of your beta blockers. So both your non-selective and selective. Okay, let's try to see. Oh, ito, mamis, may problema tayo dito, audio. Ha? Nasaan ang asterisk? Reduce? Ito? Okay, asterisk naman nakikita. Ito. Okay, they can be used for CHF. But in the hands of a cardiologist. Okay? In the hands of a cardiologist. Kaya hindi ko sinabi sa inyo because